outpatient, I think authorizations and like working with insurance is just becoming more and more difficult as time goes on. And so I still have to do like all the peer-to-peers myself.
Everybody, welcome to Be Empowered, the podcast. This is a podcast where we dive into the realities of healthcare and entrepreneurship. We offer our opinion, unfiltered and apologetic, and always with a dose of empowerment. We're here to amplify voices, both yours and ours, challenge the status quo, and explore what it truly means to thrive. I'm Dr. Santoshi Bilakota.
And I'm Dr. Shala Mokbel.
So let's get into it. Today, we have a very special guest. We have Dr. Neha Damle, who's a board-certified oncologist. And she's here to talk to us a little bit about her experience being a woman in medicine, how she maintains her work-life balance, and how she deals with some of the bigger challenges in medicine today. So Neha, thank you so much for joining us. I hope that was a proper introduction. If you don't mind sharing a little bit more about yourself to the audience.
Sure. Thank you so much for having me. I'm Neha. I'm one of the hematology oncology doctors here in the Bay Area. I practice actually in Napa as part of Queen of the Valley Hospital. And I'm pretty much a Bay Area native, I would say. So, kind of raised here, and then did my undergrad at Berkeley, and then took a very sharp turn to Virginia for medical school. Different, to say the least. But then, as most Californians do, we flock back to the Bay, and completed my residency and fellowship training here. And I've been in Napa ever since the pandemic. I am a hematology oncology doctor. We sort of see all types of oncology cases, and we don't have super specializations, though, myself and both of my partners do kind of have areas of interest, and I tend to do more of the breast, GYN oncology in our group.
Neha, did you know I went to medical school in Virginia as well?
You said that, right?
Yeah.
You went to UVA?
I went to UVA for undergrad, and I went to VCOM for medical school.
Yeah.
What a small
world. I
world.
was at VCU for med school.
We were an hour apart, and then we ended up on the West Coast, just 10 minutes from each other. What a small world.
I know. That's great. It's very different. Like Virginia, at least Richmond, like where VCU was, is like worlds different from the Bay Area. Northern Virginia, I think, is a lot more similar to this area.
Right. Yeah. So let's get to it. I will start with the first question. So what are some of the biggest challenges that you have today as a doctor?
She's like, how much time do we have?
I know. Yeah. I mean, in all honesty, I think most doctors would say this, but over time, it's the general degradation of our autonomy in practice, just constantly being asked to do more with less, and our compensation not being commensurate to the amount of work and training, honestly, that we have to put into it. And unfortunately, I just think that process has gotten worse over time. For me personally, it's a lot of, we should be able to get our patients timely, high quality care without, I think, having to jump through the 10,000 hoops or spend an inordinate amount of time that's uncompensated, unpaid for, outside of the bounds of normal work hours in order to be able to actually get that patient care delivered, which I think all just fits with that lack of autonomy.
Right. Are you in private practice, or you're still considered part of a hospital system?
It's a little bit of a hybrid. So the closest I liken it to is Sutter, where Providence Medical Group technically owns our practice and the hospital, but there are certain groups that work within the hospital, but they're not with Providence. So our cardiologists are actually with Sutter, but they practice within Queen of the Valley Hospital. So I guess I would say, yes, I a managed care organization, though there are still some private practice aspects to it. that is slowly going away as well.
So do you do both inpatient and outpatient or primarily one
Primarily, we are outpatient
patient?
doctors.
Mm-hmm.
Because we have a contract with the Queen of the Valley and our infusion center is actually within the hospital, we do kind of
Mm-hmm.
staff the infusion center. And then if our patients like wind up in the hospital, then more as a courtesy, I would say we follow them, but we're predominantly clinic based.
And so do you have a lot of APPs that work with you guys as well?
We have one APP in our
Okay.
practice in Napa. Our oncology group has like a sister group up in Santa Rosa, which is slightly bigger, and they, I believe, two APPs. So we have one nurse practitioner who works in our office 3 days out of the week, and she handles a lot of our like sort of more routine cases, just kind of like standard chemotherapy follow-ups. And she does a lot of our teaching education, like on chemotherapy, oral drugs, immune therapy as well.
What do you feel about APP roles?
So I know that it's recently become a very controversial topic in medicine. I actually believe that they absolutely can play a role, and they have, if their role and their sort of education background is appropriate, I think they can actually be a great resource for many practices, because you can offload some of the more, I mean, I don't want to say mundane, but more straightforward kind of cases that, otherwise would kind of take up time in our schedule. And as long as, the APP is well trained in the field and like knowledgeable, but kind of knows when to defer to the doctor, I think that they can be a great resource. I don't know how I feel as much about APPs who sort of are like fresh out of nursing school and go into that, because I think there is a distinct lack of training experience there. But, a lot of the ones who were RNs and then subspecialized, I mean, I have had good experiences with them.
It's exactly the same for us. We've had the same experience as well. What do you think about APPs practicing independently?
I think it's a situation where you can't have your cake and eat it too. I always say to this point that, okay, except they're not actually practicing independently, are they? Because ultimately, in many of these cases, there is some overlying physician who clearly is not like aware of what's happening, like with patient care. But when things go awry, there's also a lack of responsibility taken on the APP's part. And so I'm a little bit like, yeah, I don't believe they have the full training scope and capacity to completely independently practice. I don't believe that. But, for all of those who advocate for their independent practice, to that I say, okay, but then you have to start covering your own malpractice. You want to be independent, then you have to be independent. There really shouldn't be any physicians involved if that's what you're wanting.
But there are many states, actually in more than 25 states, that allow independent coverage by APPs. California is not one of them yet, but I think it's heading towards that.
Yeah, many places are. And I honestly think it's a way, well, people think it's a way to bridge the caregiver, like the provider gap that is already here and going to get worse as time goes on. I don't believe that their training is sufficient for them to completely independently practice. Again, a lot of these straightforward kind of cases, sure, they are great resources for that. But I always feel like medical training, residency training, fellowship training, that cannot be replicated by APPs.
Yeah, especially specialty. I was actually going to say just that. Shala and I recorded a few episodes on this, and I think we're all kind of on the same page with that. One thing that also kind of drives me nuts is that term provider, right? I mean, they're
Completely
advanced
agree.
practice
Did not mean to
providers,
say
sure.
that.
No, because it's appropriate when you're talking about APPs. I think yes, provider, but what drives me crazy is when you're talking about doctors as providers, which now we're all looped together.
Yeah.
And the patient doesn't know which provider they'll be seeing, right? So I think it also causes confusion on their end. Now, I know you work mostly outpatient, so I am now more inpatient, but I used to work mostly outpatient, and I had a lot of issues regarding like prior authorizations and peer to peers and just having the ancillary administrative support, which I can imagine is probably a lot worse in oncology because you guys are trying to get infusions and all of those things authorized. How do you manage that? And do you feel like you have the proper support from where you work?
Um, so I mean, in our office in particular, we have actually someone sort of fully dedicated to obtain
Hmm.
like authorization for our treatments, whether that be like it's mostly for like the infusional treatments, so like chemo and immune therapy, and we have like a dedicated oncology pharmacist for the oral chemotherapies for patients. So I'm actually fairly privileged that way in that I do have the staff for that. However, ultimately, I get roped into a lot of this myself because, I think we can all pretty clearly say, I mean, if you guys are more hospital based, maybe this doesn't come up as much, but like outpatient, I think authorizations and like working with insurance is just becoming more and more difficult as time goes on. And so I still have to do like all the peer to peers myself. I have to, and patients don't know like my authorization coordinator or the oncology pharmacist. Like the first person they're going to come talk
They
to is,
know you.
hey,
Yeah.
doc, right? Like they're telling me I have to pay $10,000 out of pocket. What do I do for that? So ultimately, I'm still really heavily involved in like coordinating care and pointing them one way versus the other. Oh, patient assistance. Oh, grants, that kind of stuff. And again, this all has to be done, at least in my clinic, like after hours. So it's either after 5 p.m. or like during lunch, or like I've sometimes done a peer to peer call. I think the earliest one I ever did was 6 a.m.
Wow. Yeah, that's tough, man. I think that's a big reason why I left outpatient practice and probably Shala as well. It's like you're doing five jobs but being
Yep.
compensated like your one salary, right?
Yep.
So it does become very difficult, especially if you don't have the ancillary and administrative support to kind of hold you up. So how do you deal with, I guess, burnout? I'm sure that, you've been doing this for how many years now?
So 5, I guess. Yeah.
5? Yeah, yeah. So I can imagine it's starting to kind of
Yeah.
yeah.
And I mean, I would say that like my colleagues, so the two physicians that I work with and our nurse practitioner, like I get along great with them. I think they're fantastic resources. We really, I think, support each other in our practice, which I think is rare. And I appreciate that. I understand the privilege. But that being said, I think it's just the day in and day out grind. And I'm like, burnout, I'm actually like not the biggest fan of that term as well, because I think
Mhm.
it actually puts a little bit of victim blaming like on the physician as well. So I definitely think that, it is really easy to get very tired of the system that we work with. And, I've definitely contemplated like, is this something that I want to do? Back in the day, a lot of docs, honestly used to work, I don't know, 40 years till they died, whatever, I don't think that's the case anymore. I really don't think that most doctors who kind of graduated amongst our time frame are really looking for that, because it is too hard to work in this system, because you have to put in so much more, I think, than what you get sometimes. So for me, like I kind of, as difficult as this is, I like to completely divorce my brain. Like when I'm at work, I'm at work. But when I'm like on my off days or like when I'm on vacation, I really try hard to like completely like no involvement at work. And that doesn't always go smoothly. Oncology is a field where a lot of patients are like, I'm not going to do anything until I talk to my oncologist. So sometimes I still get roped in, but that's how I kind of do it, is like, if it's my day off, it's my day off. Don't bother me. I don't exist. It's like I've died.
That's great that you're able to set boundaries, basically.
Yep.
So the next question is, how do you deal or how do you feel as a woman in medicine? What are the challenges that you face as a woman in practicing oncology or even being a doctor?
I mean, I think it's really challenging. I feel like, I had always wanted to be a doctor even when I was like a kid, and I kind of just like worked towards that pathway my entire life. And I think women in particular are in a unique circumstance, the majority of them at least, that at some point they've probably been like a caregiver, caretaker, and that empathy is like inbuilt a lot more. So I actually think most women make fantastic doctors. But it can be really hard to navigate the system and kind of make decisions that fit both spheres, like your career and your family personal life. I feel like women are the ones that actually bear that burden of making that choice a lot more than male physicians, just biologically, obviously. And I think for me, that's been really hard. And they're often at odds with each other. Like the right decision for my family may not be the right decision for like career medicine job wise. And how do you navigate that?
And I think also being in oncology, right? That's difficult. Like you said, the stakes are quite high and people are really, really sick.
Yeah.
So do you find that you are able to effectively set boundaries? I know we talked about, you go on vacation and you just don't exist, but like, does your administrators, like, do they respect that or do they still call you anyway? After a while, those instances add up when
Yes.
the stakes are high, and especially in your case, like we're talking about cancer, like people are very highly emotional and it's not easy.
Yeah, I mean, it's not perfect for sure. There are many times where, yes, I am pulled into the conversation because, it's like, oh, I've been managing this patient, and like a lot of it is like the patient doesn't feel comfortable with anyone else. And so then, like, I have to be pulled back in and, talk to them and navigate the situation. I mean, admittedly not perfect at boundary setting, but I do think that for women in medicine in particular, that it's really, really important. Like, we have to be able to make decisions that protect ourselves because we're constantly overextending all of the time. Because, again, I think we're just naturally kind of empathetic people. We want to help. So it's really easy to get caught into that, like, I'll do it. I'll do it. I'll do it. And setting boundaries, I think, is really important. I don't always succeed at it. And part of, I think, what I do believe helps is putting a little bit of the ownership back on like the patient themselves. Like, I can't want the treatment more than you. If you don't show up or if you're constantly like an hour late, we're gonna set boundaries. Like, we're not gonna see you that day. I cannot fit everyone who calls for like a same day appointment. It's just not going to happen. So we have to triage. And I mean, we try to do that in our clinic. It kind of depends. Administration is sometimes on board, and then sometimes they're like, oh, just do this solid for us. And that can be really hard.
And you have 2 kids, right?
I do. Yes.
When did you have your kids, and how much time off did you take?
So my first son I had in fellowship, and that was really drama filled because navigating like, oh, how much responsibility am I putting on my co-fellows? My program was really not supportive, and it ended up, by whatever circumstance, that out of a class of like, there were 10 fellows total, and out of 10, I guess three ended up being pregnant at the same time. So that, like, I totally understood it put a lot of pressure on the program, but they were really unsupportive. They really wanted me to cannibalize like all of my sick leave and vacation, and even that I think only amounted to like 6 weeks, I want to say. And so I actually put my foot down at that point and said, no, I'm going to take like 10, and whatever those 4 weeks or six, whatever, like gap, add it on to the end of my training, which they did, and they were like down to the minute they were clocking. But I don't regret it because there was no way that I could physically have gone back at 6 weeks and then not have like any sick leave or vacation throughout like a baby's first year of life, which is frankly ludicrous to ask of anyone. My second was born when I was at this practice. So they were a lot more like understanding, I would say. We don't get paid maternity leave, so I had to use FMLA. And I was able to take 12 weeks off, but again, I think only 6 of those were actually like disability pay. So that was then at least 6 weeks, right? Completely unpaid leave.
Isn't that ludicrous? Like, it's so
Nuts.
crazy, right? Like, what are you expecting people to do?
No, I mean,
It's just,
it's just ridiculous. Like, I think I read somewhere where like by law, like they don't allow puppies to be separated from their moms like before 8 weeks of life, but we're totally fine asking that of women.
Oh my gosh. I can't believe
specifically in
that.
medicine too,
Yeah.
because you go to some of these tech companies like Amazon, whatever, they'll give you the time off.
Yep.
They'll even pay for it, some of them. But in medicine, like forget about it. 6 weeks. That's all
And
you
not
get.
even that, right? I mean, I hear ACGME rules have changed now, so that like they have to give you
Mm.
6 weeks. Again, I don't know if it's paid, but even 6 weeks is, I mean, it's like laughable, right? I mean,
Yeah.
what if you have any kind of like birth complications? And I mean, even if you didn't have any, taking care of a newborn is like maddening by itself. No one, I feel like, should be forced to go back to work really before they're ready, but we don't have that luxury, especially in medicine. And there's always like this undercurrent. I don't know if you guys have experienced it, but there's always been this undercurrent of like you're being selfish by taking this time off and like dumping your work on your colleagues, which I think is a really harmful narrative.
I mean, particularly in your situation where you took a fellowship that's 3 years, right? Hematology
Yeah.
oncology is 3 years. And you said that you had other co-fellows that had pregnancies as well. I mean, what do you expect, because other than if they don't, then they have to wait longer and then maybe deal with infertility afterwards. So we really have to talk about how to navigate around these issues of women in medicine and going into 4 years of college, and then you have 4 years of medical school, then you have at least 3 years of residency, and then you have fellowship years that could be 1 year, 2 years, 3 years, and more.
Yep.
So we're not even in the surgical fields, so I can't even imagine what those women go through. And the other factor is that your spouse is not in medicine.
Correct.
We are
Correct.
very good friends, and I know your family very well. So I think that helps a lot.
It does.
And especially, I've had co-fellows that or co-residents and co-fellows that their spouses were not in medicine, and their spouses were able to stay home longer and even help with childcare. But when you have two spouses in medicine, it's particularly difficult.
Yeah.
But I'm glad that it worked out for you. At least you could do it, because postponing that, it could be devastating, right? Because you can end up having a lot of issues that you cannot change.
And I personally think that it's wrong. Like, why are we putting any of this off, right? Like, this is not something that we should be accepting. I think I read a study once that actually showed that it's up to 25% of female physicians who have infertility issues, which is, I think, way more than the general population. But I think it's because of this, because you're on this like conveyor belt, starting from like, I mean, sometimes from college, but like definitely from medical school, where taking time off or taking a year to like I mean, it's just like, if you do it, it's difficult to navigate and can actually sabotage you career-wise, like longer term as well. I think it's like purely a result of this, that it literally gets in the way of childbearing or whatever your family plans are, essentially. So yeah, it's ridiculous. I mean, with my daughter, who was born in 2022. So like I had to take the 12 kind of weeks unpaid. My husband's company gave him 19 weeks paid parental leave, which I was like, this is like, what? You know, that was just crazy talk to me. And yeah, he took advantage, and I was very lucky that he was able to actually have that time. But it still strikes me as nuts that nowhere in, I mean, I think it's laughable. Like if you ever suggest this in medicine, literally people will laugh at you.
Yep. And the 1 in 4, yeah, that's a real statistic.
Yeah.
And there's also higher rates of divorce too for women in medicine. That's also, I don't have the exact numbers, but it's definitely a statistic. So, I mean, I'm not surprised, right? Like, I mean, look at they put us through like army training and
Yeah.
expect us to stay in
Literal
that
sleep
mode
deprivation.
forever.
Like
Yeah,
this is literal training for sleep deprivation. Like,
and the irony is you're supposed to still go to work and tell people how to be healthy. That's the irony of it all.
yeah.
You know, you tell your patients, make sure you get enough sleep and you're drinking water. Meanwhile, you haven't drank water all day. You haven't even gone to the
Eat
bathroom,
like
right?
healthy, meanwhile you're eating like
Eat
chips at the
healthy.
break
Meanwhile,
room.
you're
Yeah.
like eating whatever you can. So it's ironic that you're supposed to preach wellness and you're supposed to tell people how to, you know, prevent chronic illness. Meanwhile, you're causing it yourself, I'm sure, with the stress and the bad eating. What advice would you give to any woman who's trying to enter medicine now? Or would you not give advice and just say, don't do it?
Just don't do it.
Catch me on the right
Don't do
day.
it. That would
Right
be me and
time.
Shala. Shala and I are like, nope.
Yeah, I mean, honestly, I don't know that medicine is something that I would like necessarily encourage people to go into anymore. I do have like a couple of, you know, younger family friends and cousins who like are interested. I mean, you really have to want it. I think in today's day and age, I I don't know that the dividends like pay off going into medicine, and especially nothing like how they did back in the day. So you really, really, really have to want it. Like now I feel like it actually has to be a calling to go into medicine, because I don't think that there's enough other incentives to do it. Whereas back like in the past, I think there you could probably reliably say that there was a decent amount of money to be made like in medicine and like job security and what, like I don't even know that that's the case now. So I don't know that I would necessarily encourage it. If someone was really, really interested, then all I would say is that I hope that they would find someone to actually be, quite frankly, like brutally honest with them, because I don't know how you guys felt, but as I like kind of went through third and fourth year of med school, I mean, like I actually had a little bit of like a existential crisis where I was sort of like, I actually don't know, like if I can handle this, if I can do this, if I want to do this, because it's a lot. And I don't think I was prepared for like, again, the hours that you work, the sleep deprivation, like constantly having to potentially like you know, skip out on your own family's events to go care for someone else's family. That part was like, I don't know that I knew it going into it. So I would definitely say like whoever really does want to go into it, you should be really, really honest and like describe all of this, because this is the reality of medicine. It's not just like whatever the cool Grey's Anatomy, like I'm going to do a thoracotomy in the elevator kind of thing. You know, it's a lot more of this. It's a lot more of paperwork and fighting with insurance companies and saying, sorry, I have to work on Christmas.
You're absolutely right. Shala and I were actually saying that our jobs only look cool on TV.
Yeah.
In
Yeah.
real life, it's like, and it's so funny you say that, because in my third and fourth year, I had similar thoughts as well. I actually had those thoughts even earlier on when I was spending like 16 hours in the library. I was like, what the heck is this?
Yeah.
But then, you know, I figured that was, you know, because you're spending so much time studying. And then clinicals came around and I still just was so already burnt out.
Yes.
And I think when we made that decision, we were really young. We didn't know the realities, because quite frankly, no one talked about it.
Right.
There wasn't social media. People weren't being brutally honest. And I think even back then, things were better. So no one was saying, hey, watch out, you know, reimbursements are going down.
Yep.
There's this increasing scope creep and all of those other things. But I think it's become untenable, our generation and maybe the one after. But after that, I am a little worried about the direction in which this is going ultimately. So I wouldn't recommend this to anyone unless they really cannot see themselves doing anything else.
Yeah, exactly. I mean, they would have to literally say like, I don't care. Like I know anything and I know everything and I still really want to do it. And then, hey, maybe it really is a calling for that person and we could probably use doctors like that. But I feel like, at one point the pendulum was like one way in medicine, right? Where it probably was really paternalistic and like a lot of shady things were going down and there probably was a lot of getting really rich, in medicine or whatever. And you kind of just told your patients like, shut up and take this medication. And they did, right? There wasn't a lot of education or anything like that. Not great. But then I feel like it's completely moved in the opposite direction now, where like anyone who can Google is apparently as good as a doctor, and a lot, I think like everyone is in general more entitled and angry nowadays. Like there's much less grace given. There's much more of, well, I know better than you. Like, what is why? Like you have to prove to me that you know what you're talking about. And I think we all want education and resources to be available to people to, learn up on their conditions. But I think technology has made our lives infinitely more challenging in some ways, and it goes unrecognized, which I think is the problem. And sure, it's going to get worse with AI. So it's just like, I think it swung way too much where now we have like no autonomy. And I don't know if it will break at one point and reform itself. Usually I feel like that's how things go in this country, where things have to actually quite literally hit a breaking point, and then and only then do people pay attention and want to do anything about it.
It feels like a breaking point already,
Yeah, in some
So
ways.
if you could implement one major change to improve the work-life balance, especially in oncology or even in medicine or in the healthcare system, what would it be?
I mean, the radical answer would be to just get rid of insurance.
Is rightfully so, yes.
Right? I mean, it's kind of, it's a third party and honestly causes like a lot of trouble for most people. I think actually the answer is just like more doctors or like more physicians and more staff to support those physicians. I'm sure this is true across the country. It certainly is in Napa and the Bay Area. It's not just physicians that are in shortage, which means we have to see more patients with less time, but it's ancillary staff like our injection nurses, our MAs, that's what you need more of. You quite literally need more bodies available so that the work can be offloaded and appropriately triaged. Like, I shouldn't need to follow up on someone's PET scan appointment. Like, why am I the one coordinating that, right? That shouldn't need to happen. But if I don't have an MA, falls to me. So honestly, if we could quite literally just have more people in medicine, but appropriately compensate them, that would fix a lot of things.
I was going to say that's going to cost money, Neha.
I know,
That's
what
the
can I
issue,
say, right?
right?
Where's that coming from? The CEO of the insurance company.
Yeah, exactly. It's definitely, I think we need more bodies. We need more people for all the sick patients, but I feel like the ultimate goal is to squeeze as much as you can out of every provider, right? Or replace the doctor with someone cheaper, because what do the CEOs care? They themselves will go to doctors, I'm sure, because they have the money.
Yep.
But I was like, that's such a sad note to end on.
It's one of those things
reality.
Is the
I don't know,
reality.
is it going to take like some horrible, like if there are more APPs and, again, some of them are great, some of them are not. And is it going to take a lot of like I don't know, bad outcomes for patients before people start actually looking into this. And maybe that's what needs to happen. I don't know what to say.
I think that was part of our motivation with starting this podcast. And also, I think there's a lot of other people on socials, a lot of doctors who are also speaking out. And some of them, I hope we can get on here as well. I think it's going to have to be a collective voice between doctors and patients. Like, patients really need to be made aware that they are like pawns.
Mhm.
Unfortunately, that's just they're just being utilized in a way that is affecting them negatively, right? And then we are the face of the healthcare system, so
Yes.
they're like, you're the reason that I'm paying $10,000 and getting shit treatment,
Yep.
and it's like, actually, no, me too.
No,
I am
I'm on your
I am with you,
side.
you
Yeah.
know,
The insurance
because
companies and PR actually, I think, does a great job of pitting doctors and patients against each other when really we are the ones on the same side and it's versus all of them. But I've often felt like doctors have a PR problem, like in this country. We are constantly the scapegoat. We're constantly the ones who cost too much. Like we're the problem. The healthcare system is like bankrupt, which is like the furthest thing of what it could be. And then I think it, fosters a little bit of upset on both sides where like we turn on patients because we also feel like the patients are being really rude and entitled, and then patients think we're not doing enough. Again, this is like the relationship that is actually at the core of medicine, and somehow it has gotten completely warped.
And it's not just that, it's also we lack the support. We don't support each other. I
Oh, yeah.
think, and we don't have a union. So I think all of that plays, into this kind of being abused, really. I mean,
Mhm.
the patients come to you and they expect more. And then hospital administrative expect more. And then even, having more bodies, I don't know if it's will solve the problem of our compensation getting lower and lower. Our
Right.
autonomy is being taken away from us. So there's a lot of other problems. It's not just enough physicians, and which will get even more worse. So you would think that because the supply is low, the demand is high, then we should be compensated more. But that's not the case. Our compensation is going down and down.
Yep.
So I'm not sure. Like this is doesn't even fit the regular
Right.
economical structure that it should.
Agreed, completely. I mean, like I said, like we are the ones who are sort of thought of as being expensive, or like, the ones who are taking up the majority of the money of the healthcare system, let alone that we're the ones who actually generate the income, right? For a lot of these hospitals and private equity groups and all that. Where is the income coming from? It's from us. So it's kind of like that argument is like so crazy when they always bring that up. Yeah, I mean, our compensation is going down and more like I think the problem is that a lot of people try to change just one aspect of it and it won't work. Like you literally have to dismantle like the whole thing, right? Do we think that doctors would maybe be okay with lower compensation if you completely erased medical school debt or made it a lot more affordable to do that? Of course, right? Because you're not then starting your career older than the majority of other people out there as well, and with $600,000 of debt in tow. So it's a lot of this kind of stuff that people like don't think about. Why are residency salaries coming from Medicare?
Well,
Why?
like other countries, I mean, they, they graduate earlier, and they also don't have the medical school debt, but they get paid less, for sure. And I'm not sure. I mean, if they're struggling or not, but I don't think so. I mean, my cousin is a physician in England, and doesn't seem to be as stressed, even though they have the national health system. But I'm not sure. I'm not sure if what's the right answer, but the medical school debt is a big factor. And I was thinking the other day, if you compare a 40-year-old person in sales versus a 40-year-old person in finance versus a 40-year-old physician versus a 40-year-old engineer, definitely the 40-year-old physician is a loser, financially. No, the return on investment on that person is very, very poor.
Yes.
They're a winner because they're helping patients and they're contributing to patient care in the society. And I'm not saying that the other people's jobs are less valuable, but for sure, the sacrifices that 40-year-old made, I think, is a lot more.
Yes. Maybe it's becoming more at the forefront, but people just don't realize it, right? They're like, oh yeah, it's really hard to be a doctor, but I don't think they quite understand what hard actually entails. It's not just like studying a little bit, you quite literally have to put years of your life and your own health into this, sometimes at the expense of your family.
Yeah. And I think, certainly we can talk about this forever, but this might be a good time,
Yeah.
place to wrap things up. Is there anything else that you want to kind of add, or any other questions, Shala, that you might have for her?
I think there is a lot more, to be honest.
There's a lot more. Yeah, we
But
can bring you back.
yeah, exactly.
We talk
But
ad nauseum.
yeah, definitely. I mean, whatever subject we want to talk about, we end up recording more than one episode about it because there's a lot to talk about. But this was great. Thank you so much. And yes, we should do this again, revisit in a few months and and see where you are, where we are. And yeah, if you have any final comments, please feel free to say it.
No, thank you so much for having me. Really great discussion, and yeah, I mean, I think if we could literally just talk for days about all of this, ranting and construction, but I just think that for me, there probably is going to be a reckoning somewhere in medicine coming. And all I hope for is that we are on the right side of it.
I hope so too.
Yeah.
Well, thanks for tuning into the Be Empowered, the podcast. If you enjoyed this conversation, don't forget to subscribe, leave a review, and share with someone who really needs to hear this, which is a lot of people, not just doctors, not just APPs, not just nurses, patients as well. Stay
Yes,
strong.
absolutely.
Exactly. Stay strong, stay empowered, and we'll see you next time. Thank you, Neha.
Thank you.
Thanks.